welcome to this episode of 10 Conversations for 10 Years, a series of conversations with thought leaders in the field looking at the future of healthcare improvement. I'm Amar, Chief Quality Officer at East London Foundation Trust, and delighted that Pedro is joining us today with our special guest. Pedro, welcome.
Hi, Amar. It's lovely to be here and continue to learn together and reflect together, looking back to look forward. And Hugh, it's lovely to have you here. Amar, back to you to introduce Hugh and get us going.
Thank you. So we're delighted to have with us today Hugh McCaughey. Hugh has a fantastic pedigree in leading healthcare systems in applying quality improvement, having been the chief executive of an integrated healthcare provider in Northern Ireland for many years, and then most recently being National Director for Improvement in NHS England, leading the application of improvement across the health and care system in England. So Hugh, welcome. Thank you for joining us.
Thank you, Amar. It's a really great pleasure to join you and Pedro. It feels just like a continuation. The number of times we've been at different improvement events where we've been talking late into the evening about the improvement and how it could really transform the NHS and our commitment to it. So it's lovely to be a part of these podcasts. And congratulations also to East London. I think it's fabulous, your 10-year journey, and great credit to you and the many others in East London for continuing and sustaining that journey. And you can see the obvious benefits for both staff and patients in that area. So it's a fabulous tribute to you.
Thanks very much, Hugh. That's really kind. And obviously, you've led a similar journey in the Southeastern Trust in Belfast for many years, and we couldn't have done any of this without collective leadership across large, complex organisations. And leading for improvement is the topic of today's conversation. So Pedro and I are going to pick your brains on this one, and we're going to mull over some questions about what it really takes to lead in a way that cultivates a culture of continuous improvement. And I wondered whether you could kick us off, Hugh, by helping us think about, what the key challenges are that you see for leaders in health and care today. What sort of things are people grappling with today?
People are probably very familiar with the sort of list of things. Everybody's, we hear them sort of in media, and any commentators talk about the issues around demand, around particularly pressure on services, on staff, on sort of organizations that are providing, but also the impact of that on patients with waiting times and outcomes. And I think that sort of growing disquiet around the NHS and whether the model's continuing to work. I think we're seeing sort of high level of public and political expectation, which is weighing heavily. And I think the pressure on our workforce is like it has never been before. And so I think this is, and I suspect, if you talk to people 10 years ago, they would have talked about similar pressures. But I think we're at a point in the history of the NHS where these pressures have never been greater. The NHS is such an institution, it's so adored by the people in this country. And I think we're at a point that unless we do something radically different and actually deliver change that we've talked about for many years, but unless we actually do that, I think potentially the model, this current form of NHS will strain too much and potentially collapse, or the model be changed in a way which undermines the principles of the NHS. I would have a great concern about that. For me, probably the biggest thing, which is, people talk about the aging population and demand, but for me, it's more almost the equation of, or the ratio of people who need care relative to the proportion of the population that pays for that and is present and able to deliver it. And that ratio is changing much more quickly than the proportion of aging population. So we have more people needing care and less people able to pay for it or provide it. And I think that's the real risk. So we've talked for probably decades around needing to get upstream, needing to really talk about and deliver better health for people rather than more healthcare. And I think we're at the point that unless we do that, we're going to the delivery of healthcare and social care, which is really important part of this, is going to tip and become unsustainable. So that's the stakes I think we're playing for at the minute.
Hugh, what's your sense, given your experience in the Southeastern Trust and then as a national director of improvement, in terms of how improvement can be helpful in the challenges, in meeting the challenges that we face?
My initial piece probably sounded a little bit negative, that we're at this tipping point. I think there are choices, and there are choices that we have been talking about for some years. But I think now is the urgency with which we need to grasp those opportunities to actually really do something which addresses health inequalities, which gives children a better start in life, so that they're not dependent on public services for 50 years. That we help people to age better. That we do more to help communities that are disadvantaged, so that their mental health, and some of the great drivers of ill health, like employment, like housing, like training opportunities, and the sense of well-being of communities, there is an opportunity for us to do something about that. So, excuse me, how can improvement health help, and what can leaders do? And I think we have this a choice, but also a responsibility to not only manage the short term, and to deal with the things that are very politically important and very immediate and very urgent, but we also have to balance that with creating something which creates a better future. We have to spend time on both. We have to manage short and deal with the urgent, but we also have to manage long and create a better future, create a healthier, address some of the things which are causing ill health, and help people to stay well, and not need public services so much. It's back to that equation. How do we do something? We can't create a much larger workforce and a much larger group of people paying for the NHS, but we can do something about the other side of the equation, which is the demand. But our focus has always been on the first. We talk about health, but our focus has always been on the first 2/3 of that, on the HEAL, the healing part of it. We want to address ill health. We don't want to keep people healthy, or we haven't invested enough in that. So, what's the responsibility of leaders? I think we have a responsibility to do improvement and transformation. So that the transformation piece is, how do we change the model? How do we actually do something which helps people to age better, to give children a better start in life? And it's, sometimes that can feel very daunting, but there are really good examples of how the NHS has done transformation. Amar's World Mental Health, you roll back 25 years, the number of people in institutional care, and the model was very much based around institutional care, to now where, the element of institutional care is very different. So the model was in mental health has been changed massively, significantly. Same's true in areas like surgery, where the amount of surgery that is now done laparoscopically, or even treated medically, or done as day case, as opposed to, sort of many nights in hospital. When I was a kid, I had my tonsils taken out. I think I spent a week in hospital. And now that's, done as a day case. So surgery, we have transformed, and I think sometimes we need to look back to see that actually we have done this before. So now, how do we shift the dial so that we actually, our people, actually have a bit of space and time to do more around helping people to stay well and helping people to age better, helping children to start life, and have greater opportunities. And I think there's a number of things we need to do that. We need to work with others. We need to use data to identify, and big data to identify who are likely to be at risk, who are likely to be in need. We need to spend some of our time getting out and working with others to make sure that we actually do address ill health and keep people well and age better. But the other thing we need to do is, when we do that, how do we make sure that the new model embeds and perfects? There's a lovely analogy, I think, with this, which is, if you look at the history of the high jump since in the last 100 years. So if you go back to the early 20th century, people were sort of running up and throwing themselves over the high jump. And then, there was, people changed the model and they introduced the straddle. And then for the next and that instantly meant a sort of 30% rise in the sort of achievement of what people could do in the high jump. And then for the next 20, 30 years, people perfected that and tweaked it and got better at it and applied essentially sporting improvement tools to get better. And they delivered 30% improvement. So transformation gave 30%, and the improvement of the technique gave another 30%. Then the model transformed again into the Frosbury flop. Same thing happened. And so there's been this sort of, in this history, there's been steps where we change the model, and then periods where we perfect and improve that model. And that's where I think it's this piece around, we need to do, and as leaders, we need to create an environment where people have time to do the transformation and the improvement. And that's to me, it's not just a choice; it's a responsibility for the future of the NHS. That those are the stakes that we're playing for.
So Hugh, that's the challenge, I think. If our proposition is that this redesign or transformation, a fundamental rethink of how we approach a problem, and then continual improvement to build marginal gains, is going to take us in the desired direction. Well, what would you say to leaders who just say that they don't have the time, they don't have the luxury of the time to be able to, or their teams don't have the luxury of time to be able to step away from the day job and operations in order to even think about what could be done differently? And there is an argument out there that improvement is just too slow or too rigid. It's not enough to tackle these kinds of challenges. What's your message to leaders who have those views?
I just think I've heard it for the last 10 years. I think it's just such a folly. It is, because funny. When I started in NHS England, I won't mention any names, but a very senior person saying to me, "Well, improvement, sure, that's just the soft cushions and scented candles, um, you know, piece of managing the NHS," and that view that it was a sort of optional extra. But look at the last 10, 15 years of a regulatory and assurance based system where we try and target the organizations and services that are failing and apply significant attention and intervention to those. So we're always looking at the bottom end of the system. So that, and a top down command and control performance based model, those two elements, which have been a feature of the last 10 years, haven't left us in a better position. We've seen COVID has obviously accelerated and accentuated that, but before COVID, the decline was steady. You were seeing an increasing number of patients who were, if you take something like waiting times in ED as a proxy for demand on the system and downstream, you were seeing increasing numbers of patients waiting longer. For 10 years, that approach hasn't delivered this transformed NHS. And the problem with it has been it's been focused on managing the short term and the urgent and the political priority. But it hasn't actually helped us to transform and deliver a different model. So I think it's a folly to believe that that approach will take us from where we are now to a transformed model. What has worked? Where are the shining examples? And if you look at the outstanding organizations and the CQC's, I think, seminal report back in September 2018, when they looked at what was it that made the outstanding organizations the way they were. And one of the most, probably the most important feature in that was they had improvement embedded into the organization. Now, I don't mean improvement in the sense of a quality improvement tool. Yes, they had that. So they had the science and they had the tools. But those organizations were characterized by a sense from all staff of can do, a sense of they were empowered, they were engaged, they were able to and own the improvement for their service. That's what an improvement approach does for staff. It's culturally very different. It behaves very different. The outcomes are better. Staff feel better. I mean, in those organizations, the leadership creates the vision, creates the direction, creates the environment and the culture. But a lot of the decision making, a lot of the improvement is driven by frontline teams or leaders of frontline teams. That's what embedding improvement means in terms of how an organization functions. And the top down, and you visit organizations that have that culture and they can maybe keep things going for a while and they can get short term successes. But it's at a huge cost, A, to those leaders who are running consistently and making every decision. But also on the staff who work there because they feel disengaged, they feel disempowered, they feel they don't have any influence or authority, and that becomes a difficult place to work over time. And when you look across the NHS at the minute, so many of our staff feel beleaguered, feel that they're working in a system where they feel like victims, that they don't have the authority or the ability to change the pressure they're under. Organizations that embed improvement, staff feel differently. They can change things, they can make things better. They maybe can't at that level transform the model, but they can certainly make improvements to their service for their patients. And that's incredibly liberating for staff. Those organizations do better. The evidence is there.
So we started with challenges, then you help frame how improvement can be helpful, then you help frame as well a response to people who maybe have some doubts around the speed or pace or spirit of improvement. And now, as we kind of zoom into the behaviors, let's say, we'd love for you to reflect with us on what leaders can do actually through small acts, through maybe regular habits and rituals that can either make or break a culture of quality improvement within the organization.
I mean, the first thing to say, I've made it sound very simple. That in a sense, engage and embrace improvement, and you'll get to a better place. And that's my belief. And but I think it's more than my belief. I think the evidence there. You look at the CQC report, the outstanding organizations. That's what they do. There's a sense of collective ownership. So, but it isn't simple. Most leaders are under incredible pressure from above, in a hierarchical system. And this goes right to the political level, right to the very top of the political level, where people want to see short term, attractive results for the NHS and on a small number of things. So those things end up becoming where the attention is put. So leaders working in the system feel that pressure. So it isn't simple, but there is a bit about, excuse me, the leap of faith, which is you've got to, if you don't start this journey, then you'll never make the improvement. You'll never create a different culture. And I think for me, what leaders have to do is actually do both, which is yes, you have to find a way to deliver some of the short term. So, even in my journey, I'm sure it was the same in Amar's, you have to deliver what's wanted from above. But that doesn't, you find a way to manage those short term goals. but you build a different approach in parallel with that. And at times you actually have to, I think, act like an umbrella for the organization, protect them from some of those external pressures, find a way to deliver those, or certainly not see a deterioration in them while you build a different approach. What do leaders actually do? I think they have to start the journey. They have to be stick with it. Um, they have to demonstrate. They have to be relentless about it. It requires that sort of persistence over a period of time. And it certainly isn't launch a QI strategy and then get back to the day job. We lose our authenticity and our credibility as leaders when staff see us say, we're going to do improvement. There's it launched. Now we'll get back to looking after the money and the targets. Then staff, they think it isn't authentic. They think it isn't real, and actually they lose trust. I think in their leadership, and they lose trust in improvement as a vehicle to a better place. So the things I think leaders need to do is they need to keep going. They need to keep doing this in tough times. It has to be part of how you deal with the hard stuff. You use improvement. And it really interesting during COVID, that many of those outstanding organizations used improvement to deal with some of the issues they were having to deal with. Organizations where it wasn't embedded paused QI, and went back to sort of command and control and dealing with those urgent issues. But those the outstanding organizations, it was part of how they deal with things. Improvement and the tools they had was embedded to an extent that was how they dealt with any issues of the day. And for an organization that's starting out, that can seem a long way away, but and it takes time to build that. But if you don't start that journey, and you can see, you'll never get there, and you can start to see, when you apply and target the improvement tools and skills on specific things, you can see improvements in those areas, and that helps to build momentum. What are the little things leaders do? I think it is, and maybe the first one isn't little, but it is, creating that purpose and vision and that commitment to embed improvement and to have a particular type of culture. But then I think it's the lots of the little things you do are be visible, go and visit teams, take an interest in where people are using these tools, where they're actually starting to uh, make changes themselves at a team level. Really need leaders to be visible, show an interest, celebrate when staff do this, show that it's valued. When staff see, I remember as a chief exec visiting teams, and when you just take it's people underestimate the impact it has when leaders visit, show an interest, ask questions, and sometimes even remove barriers for teams. Then they know that it doesn't matter what we say at a launch of a strategy. It's what we do around a board. It's what we do and what we ask and what we show an interest in when we visit a ward or a department, or importantly, because I think this needs to extend into social care, when we visit a team in the community or when we visit in my case, a children's home. It's showing an interest in those things, being visible. That's when staff know it's authentic. That's when it really starts to embed.
Thanks, Hugh. That's really powerful. Your description reminds me of a fantastic book called From Good to Great by Jim Collins. I think the analogy goes beyond healthcare. People listening to this may well be coming from different parts of the world, inside or outside of healthcare. But I think that the ingredients of leadership, what Jim Collins describes as level 5 leadership, of that personal humility, but that professional will to deliver results, I think is very similar in what you're describing in improvement-minded leaders, and what Collins's research over 5 years across different industries has also shown about companies that can go beyond the rest of the pack and achieve greatness. I totally concur with you, Hugh, that this is not easy. This is definitely not easy for leaders, and certainly been my experience and our experience here, that keeping that collective leadership for improvement is tough at times, when we're all facing pressures from within and from without our organization. And with the turnover that we see in executive roles as well, to maintain that belief and the purpose is tricky. I think your tips around how to bring it to life are really important for us. And I'm reminded of some of the findings from what I thought was a really powerful mixed method evaluation of culture in the NHS that Michael West and Mary Dixon Woods conducted a few years ago now, really thinking about, what were the traits of leaders in organizations where they seem to have a positive culture around quality. And they talk a lot about the balance between dark spots and bright spots. And as leaders, making sure we are consciously and intentionally paying attention to the bright spots and spending time on the things that are going really well and the teams that are doing fantastic things, and finding ways to bring joy into our own experience as leaders and the things that excite us, as well as spending time on the areas that are not doing so well and struggling and need our support. I think that's important, and bringing it to life with standard work like walk rounds or going to the Gemba, structured ways of being visible at the point of care and asking questions that can reinforce this approach to improvement, the autonomy of the teams to be able to make tests of change. Those sorts of things I think can be so powerful, can't they?
Amar, a few years ago in the Harvard Business Review, which I think is just another version of what you've described, which was an analysis of leadership styles. And the one that they advocated as being the most powerful was a thing called ambition, which was leadership that was characterized by humility, but was driven by ambition to make a difference. And that to me has, I suppose, is probably the leadership style that I feel is most powerful. And when I see the leaders I admire most, certainly exhibit that style of leadership. And we these are difficult jobs as leaders. It's a very difficult time, and we need people who have the ambition to actually take the NHS to a different place, take the way to change the culture and the approach so that it is a better working environment for staff, to change the model so that we get better outcomes for our patients and for our communities. And importantly, I think to work with others, because a lot of these things about upstream or improving health and well-being, it can't be done by doing more healthcare. It's done by working in partnership with education, with other departments, with local authorities, but also importantly with communities, so that communities can help co-produce the solutions, the better ways to keep them and their communities healthy and well. And we've got to get much better at that. You mentioned something about the change in leadership, and that to me, Carrick, when you asked the question about is improvement too slow, if you look at the regulatory based model, special measures, in the 5 years before I took up the post as National Director of Improvement, the 10 organizations that had been in special measures the most had, I think it was 49 chief execs between them in 5 years. So the chief exec was changed every year. Is it any wonder they didn't, come out of special measures? Is it any wonder staff didn't buy into a different approach and culture? Is it any wonder that they couldn't fix some of those intractable problems? We need leadership that has some longevity and can build. Leadership, I think, is about cultivating a different approach and a different culture, and helping to transform the model, so that improvement is embedded. You can't do that if you change your leadership team. I have one lovely story which, to me, I think illustrates the power of when it's embedded and staff own this and really um, own the outcomes for their service and the quality of their service. We did a presentation, I think it was about 6, 7 years in, on our journey at the forum, but we decided to do it from three different perspectives. It was me, the chief exec. There was a sort of quite a senior therapist who'd been involved in improvement for 5 years and was telling her story. But there was a wonderful guy called Andrew Patterson, who was a band 3 phlebotomist at that time, and he told his story, and it was brilliant because it was the most powerful, because he got a standing ovation. He told that the story around for the 2 years before he got involved in improvement, he'd had 60 days sick. He'd lost his drive, his motivation. He hated work. He then got involved in improvement, and through an improvement project, and as a band 3, he led that, and he said it changed his life. That he suddenly was responsible for things. He felt he had an influence. He felt he could make a contribution. He felt, and this is really important, he was connected to his purpose of quality care for his patients. But the real prize for those that don't believe was 2 years previously, we tried to reduce our blood usage on our wards to try and make a financial saving. And we'd set a target, I can't remember, it was 10, 15, 20%. And we failed. The executive team, then through the hierarchy down through the organization, tried to reduce blood usage. And we failed. Andrew led a project, a band 3, which he owned it, and he achieved a 42% reduction across all his wards, because he knew how it could be better, and he was given the tools, but an environment was there where he could do it and he could deliver improvements, and so that it resolved an issue around a shortage of blood. It saved money. It was better outcomes for patients. But that was led from the bottom up. That's what happens when improvement is embedded in an organization.
Hugh, I remember meeting yourself and Andrew for a beer the night before, and Andrew was very nervous about standing in front of people to speak, and he was also very proud of what he had done alongside other people. So I connect with that feeling deeply. And for both of you, I suppose I'll go back to two people that I, since you're mentioning other references that you go back to frequently as you reflect on leadership. One is Temen, right? Who I continue to learn a lot from, and he's first of the 14 points, which is about constancy of purpose. And Hugh, I think you've reminded us of that throughout this conversation. And the other one is highly admired, at least by me, let's call him community organizer. He's much more than that, called Marshall Gans. And he has a definition of leadership, which I have always enjoyed and kind of looked into when things have gotten tough. And he has 4 components. So leadership is about accepting responsibility for enabling others to achieve shared purpose in the face of uncertainty. And from your framing of the challenges through to your very pragmatic tips, I think you've exemplified how to live through a definition of leadership that is about this, accepting responsibility for enabling others to achieve shared purpose in the face of uncertainty. So, Amar, at least I am very grateful for the time that we've spent with you here today, and to you and everyone across ELFT for leading in such a generous and partnership-oriented way. So I'll give it back to you to help us close.
Thank you so much, Pedro, and a huge thanks, Hugh, for joining us today, sharing some pearls of wisdom and some insights to help us all as leaders think about how we can better serve those in our communities and in our organizations. So thank you so much for joining us, Hugh.
It's been a pleasure, Amar, and I suppose actually I had one final bit of advice for anyone listening and starting their journey is, through my last 15 years, I've gained and sustained by having connections with others that are walking this journey. So you, Amar, Pedro, but many others across the NHS who helped and wanted to do this as well. And by doing it together, I think we were able to sustain our progress. And my advice to anyone starting this journey is build your connections. There are people like ourselves and many others who want to help people make this journey. So reach out, build your connections, draw on that expertise that is there, and share the journey with others, because it's much easier walk together than alone.
Fantastic. And with that, a huge thanks, Hugh. Thank you, Pedro, and thanks everyone for listening, and hopefully see you on the next episode.